We started talking last week about fetal monitoring in special circumstances. And last week we discussed sepsis, pyrexia. This week we're going to talk about medications for about 25 minutes. And then we're going to have another case discussion. So fetal monitoring special circumstances in medications. Okay. When we are administering a medication, it's important for us to think about why are we giving it? Yes, indication is always important. But when we talk about CTG, we need to figure out, okay, what does the indication that we're giving it for look like on the CTG? So if I'm giving it for fetal distress, what does fetal distress actually look like? If I'm giving it for hypertension, does that have an effect? If I'm giving it for hypotension, does that have an effect on the CTG? Okay, what is the clinical picture supposed to be looking like in general? And once I've given a medication, what am I expecting from it? So if I'm giving a tocolytic, for instance, I'm looking for contractions spacing out. Okay, they're not going to stop, but they're going to start spacing out. If I'm giving it for fetal distress, I'm expecting that the signs of distress improve. Okay, what are the signs of improvement? So if the clinical picture is getting better, okay, what does getting better look like? And what are the signs of improvement that I'm supposed to expect? And I need to have that in mind because we don't do magic. As much as I'd like to believe that we do, we actually don't do magic. So there is going to be a process of improvement. It's never going to suddenly just miraculously all become perfect. It doesn't work that way. And it's also important to realize, okay, so what if my medication is not working? Or what if my medication is actually making things worse? What is that supposed to look like? Does that make sense? Okay.
Yes.
Yes, thank you. And does my medication add any extra risk to this baby? Because if there is more risk, then I need to be able to factor that in as well. So these are just the broad lines that we are going to be talking about with any medication that we're thinking about. Okay. So let's start with the things that we use most commonly. Uterine stimulants. Yeah. Most of our women get, or not most, hopefully not most, many of our women get induced, and a lot of them are on syntocinon once they are in labor or during the process of their labor. So what is that supposed to look like, and how do I factor that in? Okay, so let's start off by the indication. Why do we need the uterotonics? I really don't do well when everybody's on mute and I can't. Otherwise, I'm going to start asking, naming and shaming.
So the uterus contracts.
So we need the uterotonics because the uterus, so that the uterus contracts. But why do we need it to contract? So we're either inducing labor or we're augmenting labor. Yeah.
Mm-hmm.
Okay. So is there any difference? Does it make any difference why we're giving a uterotonic? Of course it does. It has to. I wouldn't have asked the question otherwise, no? So what is actually induction? Induction is starting contractions when you have nothing already happening. So the uterus is actually not contracting at all, or she's not in labor. She's potentially having occasional tightenings, if that's the case, but we're not actually in labor yet. While augmenting is there were contractions, they're fading away, or they're stopping, or potentially not effective enough. So if they're gone, we're either restarting the contractions or we're increasing their power or frequency. Yeah. The reason I'm saying this is because each and every one of these is gonna look different on the CTG. And the first part we said is we have to figure out what the clinical picture of our indication looks like on our trace. Does that make sense?
Yes.
Okay.
Yes.
So let's start by the induction, the first one. Somebody who's coming in who's being induced. The first thing I have to think about, okay, what risks are being posed by the indication of induction? So if this is a post-dates or post-maturity, yeah, that's why we induce most of our women, or reduced fetal movements, preeclampsia, premature rupture of membranes, meconium stained liquor. These are the indications of inductions that we have. Okay. Obviously, if you are putting if you are adding or you're stimulating the uterus, you always have the risk of hyperstimulation. Okay. What would the risk from post-maturity look like on the trace? If a baby is post-mature,
The lower baseline?
so that's the normal base. So that's what I would expect for normal for this baby. Okay, so most of those babies would have a lower baseline. Okay, so potentially starting from 110, 120. Yeah, but we also are trying to induce this baby because it's post-mature or potentially getting to post-mature. So you are actually, the risk that you may get from this is chronic hypoxia. So you need to be able to look at, okay, well, this is the indication I'm giving it. What does that indication pose as a risk to my induction, to this baby? And here it would be chronic hypoxia. Okay. What about premature rupture of membranes? What risk would that bring to this baby? Why do we induce premature or prolonged rupture of membranes?
To reduce infection.
To reduce infection. So the picture that I would look like as from my indication would be chorioamnionitis. Does that make sense? So that's what I need to look for on the trace. Okay. What about meconium stained liquor? So once again, chorioamnionitis, because that's infection, yeah. Or I need to make sure that the white deep deceleration, so the baby is not becoming more hypoxic or the subacute hypoxia that develops. And that's triggering the meconium stained liquor. Obviously with meconium, you also have to factor in chronic hypoxia. Very important. Yeah. So keep that in mind. If you see meconium, look for all three actually. Is there signs of any chronic hypoxia? Is there signs of chorioamnionitis? Is there signs of ongoing stress, so the wide deep decelerations? Okay. And obviously, if you're hyperstimulating, the risk of the subacute hypoxia picture on the trace. Okay. Just out of interest, what does hyperstimulation look like on the trace? Or what do we call hyperstimulation?
So tachysystole that's causing fetal distress. So it can be a rise in baseline, reduced variability, or plus or minus decelerations.
Okay, so just the tachysystole. So does she have to be contracting more than 5 and 10 for it to be called hyperstimulation?
Well, not necessarily, because she might just have a hypertonic uterus.
Yes.
Consistently.
So, yes. So hyperstimulation, you can't just figure out by the frequency of contractions. It always has to be a proper assessment. Most likely, actually, manual palpation, because that's the only way for you to figure out the tone in between and how strong the actual contraction is and how long the contraction is lasting. Yeah. So she may be contracting 1 to 2 in 10. Yesterday, we had a lady in theater that was contracting about 2 in 10, but each contraction was lasting about 2.5 minutes. Okay. Baby was fine with that, but obviously some babies would not be. 2.5 minutes is a little bit too long for some babies. Does that make sense?
Mm-hmm.
Okay. So if my stimulation is working, okay, what am I expecting to see on the trace? Contractions. I'm giving something to induce contractions, so I'm expecting to see contractions on the trace. And I now know what to look for when I'm talking about the risks that are imposed by the indication. Yes? So if I see somebody during induction that has a tachysystole, how do I manage that? What do you do? Somebody who's just had a PROPES put in and is now contracting 6 and 10.
Take out the PROPES.
Take out the PROPES? Does anyone else agree with that?
I think it depends on how strong
If the
they
baby,
are. If the baby's coping really well with it, sometimes you can just observe if they're not that strong, because then they can just settle down.
Okay. Anyone else
But
have a
you
different
certainly
opinion?
wouldn't take CTG.
So the difference, if we're talking about using prostaglandin, it depends upon obviously the medication we're using. If we're using, I've just asked about Propes, we're using prostaglandin. It depends upon whether it's early in. So I've literally just put in the Propes and she starts getting this tachysystole. Most of these women can't feel those contractions, as Vanessa was just saying. If she can't feel them, they're not that strong and they are still 6 and 10. If it's early on and the baby is not showing any heart rate changes, you can potentially leave it in. Most of this is just the initial response from the prostaglandins going in. Okay, you can happily observe. But if the baby's heart rate is changing, then you definitely need to take the Propes out. That means that these contractions are already distressing the baby. Now, the manufacturer from the Propes pessary talk about that the prostaglandin is out of the system within 10 minutes from removing the pessary. That's never been my own experience. Prostaglandin usually lasts for between 4 to 6 hours. Even if it's within, so if you put a pessary in within an hour and you're now getting tachysystole with baby's heart rate changes, if you're removing prostaglandins, you need to tocilize. Obviously, if it's prostin, you can't take that out. If it's in, it's in. Most of prostin, or I used to give prostin as a gel. You can't wash that out, although in the very old days, we were instructed to do so. We used to run saline drips into ladies' bits.
what? That's hilarious.
Yeah, that's hilarious, yes. And it never worked. It never made any difference.
What a surprise.
The idea was trying to wash out the extra prostaglandin from the vagina. Never worked.
That is really weird.
Taking out a pessary or a tablet, I would always give tocolysis, okay? And I would usually give terbutaline. Terbutaline works for about an hour and a half, maybe 2. By the end of the hour and a half to 2 hours, they're usually still contracting and they're more regular and the baby's heart rate has been better, okay? Taking out the Propes or the prostin tablet by itself usually does not just work. So have a very low threshold for actual administration of tocolysis, yeah?
Can I just ask with that, when you say fetal heart rate changes, do you mean like the baseline, or are we just including any kind of shallow D cells or any kind of?
You've seen that the baby, she's contracting now 6 in 10. Baby is properly decelerating with those, okay? This baby is not gonna make it for long. Even if the baseline is maintained at the moment, okay? You really need to try and figure out whether this baby is gonna cope. Remember, you're inducing. You're starting from 0 points, and you have a baby that's now contracting 6 in 10, or a lady who's is contracting 6 in 10, and the baby is decelerating with each and every one. Do you think this baby is going to carry on for the rest of labor with that frequency of contractions?
Yeah, probably not.
Okay. Even if it's fine at the moment, she's contracting 6 in 10 within the hour that you've just put the Propes in. Do you really think that in 2 hours' time, the contractions are going to be just 6 in 10? Or are they going to be more?
Yeah, more. Yeah.
Does that make sense?
Yeah.
Okay. If you manage to take it out early when baby is not showing actual stress, you may get away without needing to tocilize. Because the prostaglandin that is in at the moment is going to be fading out over the next few hours. Hopefully, you're not going to have more and more contractions. However, never take her off the trace until the contractions have settled.
Got it.
Okay. Now, if the Propes or prostin has been in for 4, 5, 6 hours, this is not going to go away. If you now have a tachysystole, you need to take it out. It's not going to settle. This is not the initial phase of irregular fast contractions. This is gonna end up with problems. The prostaglandins are now well running into the system. They're not going to go away.
Okay.
Does that make sense?
Yep.
Okay. You also, if you're taking out the ones in the early phase, you're not going to actually end up inducing anyone, because many women get this initial tacky tightenings, not really tacky contractions at the beginning. If you just take out the PROPES from all of them, you will never get anyone properly induced.
Yeah.
But the latter phase of the induction are the ones that cause most of the problems.
Sure.
Now, if you're inducing by oxytocin, however, oxytocin has a short half-life. You can easily reduce the infusion rate. Yeah?
Can you go back? You know when you were talking about hyperstimulation?
Yeah.
Just the sort of the difference between having decelerations or a raise in baseline, because I think quite often we're missing the raise in baseline on antenatal.
So the reason I said we were talking about the decelerations, so Fatima was asking whether the fetal heart rate changes mean just the decelerations, or do we also need the change and rise in baseline? Okay, rise in baseline, that's obviously, baby, this is gradually evolving hypoxia. There is no question that we need to make this baby happier.
No, sorry, I meant, you know how sometimes you don't get any details on the antenatal ward, you just get that raise in baseline, no other changes at all.
Okay, so one of the problems with prostaglandins is that it does in itself increase your core temperature, or mom's core temperature. So if there is a rise in baseline with no decelerations to precede that, that is most likely sepsis or temperature until proven otherwise. That's not hypoxia. Okay, we need to look outside why this is happening. I mean, if it's chronic hypoxia, that this baby's not responding at all, that can be another reason. Okay, because the problem with prostaglandin is you monitor once every 6 hours. So there's a gap that you may not have seen what's been happening. If you go in and 6 hours later, and now you can see a raised baseline, reduced variability, no responses, that is this is decompensation, gradually evolving hypoxia. Okay? What I'm talking about, or what I'm assuming that you're asking about, is the baby that now has a higher baseline, has good variability. You stimulate this baby and it's happy and it's accelerating. Okay, this is a lady that probably has a higher core temperature. Okay, you need to start thinking about, okay, do I have risk factors for sepsis? Do I think that this is sepsis ongoing? Or why did this baseline go up? Babies do not raise their heart rate for no reason. Okay, in this situation, it also has to factor in, okay, well, if we are showing signs of subclinical chorioamnitis in the induction phase, okay, is this baby well enough to carry on? Okay, I need to look at the bigger clinical picture, but you can't put a blanket response for that, because if it's just about a slight rise in baseline with a slight rise in core temperature, that settles with paracetamol, and this baby is showing absolutely no other signs apart from a slightly faster heart rate, this is not necessarily chorioamnitis. This is the core temperature going up with prostaglandins. You can bring it down with paracetamol. I mean, temperature is damaging within itself. So babies get damaged by the temperature. Am I making things more confusing now?
I tell you what I was talking about. So Susanna quite often prescribes terbutaline to women on the antenatal ward. She says that even though the contractions aren't strong enough to cause decels, just having a sort of more of a tonic uterus can cause the baby's heart rate to raise. So I'm sure you've done it before as well. You've given terbutaline and then the heart rate comes down.
Okay, so you're talking about the high tone.
Yeah.
Okay, if there is high, remember the first thing we said, hyperstimulation, you can only diagnose by proper palpation. You have to examine this patient. It's not just about the CTG. Okay, so I have seen women who I went in because they had no CTG changes, according to everybody's saying, and they said, oh, they're not even contracting yet. And what I found was a titanically contracted uterus that's basically not relaxing at all. It's fluctuating so minimally with a very high tone in between that Once I gave her terbutaline, you could actually see the contractions. Okay. If you think the baseline has gone up because of hyperstimulation, okay, it's not very common, but it is, yes, it does happen. And I now know what you're talking about. But remember, that's the point when this is raised because the baby it's a titanically contracted uterus. There's a high tone all through. So the baby is not even getting proper cord compressions. It's just not getting enough oxygen, full stop. Yeah, but that is not the common picture though. In general, if there is heart rate changes, that probably means that this baby is becoming unhappy. Okay, try and figure out why. This needs a deeper look into it. And try and take the induction or the stimulation out of the mix and see how this baby responds. Yeah, does that make sense? Okay. So the next type of stimulation, obviously we said if it's oxytocin has a shorter half-life, it has a shorter efficacy, so it doesn't run for as long. Basically, if you're hyperstimulating with oxytocin, you can reduce the infusion rate. You don't have to completely stop it. If things are not improving, okay, then you completely obviously have to stop it. If it's still not improving, then you need to tocolize. You won't reach the point of tocolysis with most oxytocin infusions if you stop it in a timely fashion. But it's always there if nothing's working. Does that make sense? One of the issues, but it is more with augmentation than with induction, is the increasing sensitivity to oxytocin. So we start off with somebody who wasn't contracting very much, and then suddenly, because the oxytocin causes reflex increase in sensitivity on the uterus, you end up with the smaller dose hyperstimulating. You turn it down and it's still hyperstimulating because it's doing it itself now. The woman's doing it herself, endogenously. Okay. Shall we carry on? So we said induction is we don't have contractions and we're starting them from scratch. Now, why would we need augmentation? So augmentation means that the contractions were there and they have stopped. Most of you have always heard me saying we don't really know why contractions start, but we know that what keeps them going is the Ferguson reflex. It's basically the baby's head stretching the cervix, causing reflex contraction of the uterus again, or stretching the perineum. So most of the time, if the contractions were there and then have stopped, which is what I hear frequently in the second stage. Oh yes, she was contracting very well on her own. She's now fully dilated and suddenly the contractions are only now 1 in 10. Yeah, there's a malposition there. Even though the head was stretching the cervix at the beginning, the moment the cervix is gone, the head is now not stretching the perineum. So the reflex has broken. Most of the time it's a malposition, okay? Or baby's head is now not fitting in the pelvis anymore. It's just holding on the pelvic bones, okay? Or we've been stimulating this lady for hours and hours and hours, and the uterus is now exhausted. And don't forget infection, okay? Malposition, not a big problem. I love those babies. We managed to correct the positions, or many of them correct them by just a bit more pushing. I personally, I don't like oxytocin in the second stage, and I rarely use it. If the lady has been finished the first stage with no oxytocin, I almost never start oxytocin in the second stage. The reason being is that there is a problem that I need to manage rather than just forcing the uterus to contract even further, okay? If she's been on oxytocin during the first stage, I would carry on. I would not stop that, okay? I may increase it slightly. But oxytocin in the second stage is a gray area, a very gray area. Vanessa, you don't look very impressed with that.
No, I get what you're saying, and I know that there's a lot of consultants that do and a lot of that don't. But I have also, what do you do if it's not deliverable, and say it's just a little bit asynclitic, or I don't know, it just isn't. and it just needs a little bit more power to then get on the pelvic floor and rotate. Isn't that not better than a cesarean section? I'm not a doctor, but
I'm not saying it's a cesarean section. What I'm saying is that figure out why the contraction has stopped. Most of the time, the baby was moving through. It's getting stuck for many reasons. Okay, one of the most common is a full rectum. Okay, and many women we've delivered with just giving them some glycerin suppositories. Okay, or a full bladder. Okay, or that the baby's head is now caught on the balloon, the Foley catheter balloon, and now that's why it's not fitting in. The baby has managed to dilate the cervix even though it was in the wrong position. Most of the time, it will carry on fitting through, rather than just forcing it through. Yeah. I'm not, as I said, I know many people use oxytocin in the second stage or started in the second stage. I'm not a big fan personally. That's my just personal experience. The other thing you need to always be cautious of is uterine exhaustion, because that's now your indication that things are not going to be going well with this delivery, and you're going to probably have a PPH afterwards as well. Okay. From the baby's point of view, remember that this baby has been using oxytocin or under oxytocin for the last 12, 14, 15 hours. Be very, very mindful of what's going to be happening with this baby's heart rate. Keep a very close eye, because this placenta probably doesn't have a lot of reserve now that it's been working for the last 12 hours. Okay. And always be very mindful of hyperstimulation. Okay. Uterine stimulants, okay?
Yeah. Yep.
So the opposite is now tocolytics. When do we want to relax the uterus? What tocolytics do we know in practice? Let's talk about what tocolytics do we know or do we use?
Butylene.
Butylene, salbutamol, yeah. Do you know how it works? How does it work?
It's a beta agonist, beta 2 agonist.
Yes, it's a beta 2 agonist. That's very correct. And that relaxes the smooth muscles. Yeah, it works on the uterus. It works in a similar way in the lungs, and that's why we give it to people who have bronchial asthma. Okay. Any other tocolytics that we know of?
Yeah.
Yeah. Come on, guys.
Nifedipine.
Nifedipine or GTN.
Magnesium.
Yeah. Magnesium. Anything else?
There's one in 2 different bottles. One was pink and one was blue. We used to use it all the time, and I can't think.
Is that like a Tosiban or something?
So a Tosiban, yes.
That's it.
Yeah, a Tosiban. How many times have you used that?
Never.
How many times have you seen it?
Never.
We used to use it here all the time.
Wow, you guys are rich.
We don't anymore.
No, I don't. I haven't seen it for, I think the last time I saw it was about 11 years ago, pretty much when it was coming out. And I only saw it at St. Thomas's because they had enough funds to support that. But I've not seen it in any hospital since then, actually. But so these are the main 4 that we use potentially for that purpose. One of the things that always don't forget about is non-steroidals. They are a tocolytic. So be very cautious if you're giving a tocolytic when you have a PPH. That's why we don't give diclofenac after a PPH, because it's going to relax the uterus even more. Does that make sense? Obviously, non-steroidals also have an effect on platelets, so we don't want her to be clotting less and less. But the ones that we use frequently are terbutaline, GTN, nifedipine, and potentially magnesium. Do we know how GTN works?
Does it just restrict the blood vessels?
It's the vasodilator.
It's a vasodilator. Yeah. It's a strong vasodilator. So it relaxes all smooth muscles within the body with potentially quite a strong hypotensive effect. Very similar to nifedipine, although nifedipine is a calcium channel blocker. Yeah, it causes relaxation of all smooth muscles through blocking calcium, which, by the way, is the same way that magnesium works. We're going to talk about that again, them again when we talk about hypertension. Yeah, but that's how they basically work. Why am I saying all of this? Okay, remember we said we need to figure out what the indication looks like, what the effect of the medication looks like, and any risks that it poses. We're just doing the CTG teaching. The CTG teaching? The CTG teaching session. Yeah. Okay. Okay. Sorry, guys. Are you still following?
Yes. Yes.
Okay. So when we're saying about the indication, let's talk about terbutaline. So the indication here is potentially fetal distress or hyperstimulation. The intended benefit is that we're expecting that the contraction starts spacing out. Yeah. The clinical picture of the effect is that you're going to start seeing that on the TOCO, the contraction of spacing out, and hopefully reversal of your hypoxia. Yes. Now, when it comes to terbutaline, that's a very important thing that you need to look out for. Let's imagine that we have a baby that is running into distress. So we started off with a normal baseline. This baby's baseline is about 130. Okay, it's now getting more distressed. So adrenaline starts to come out. And with the adrenaline coming out, the baseline goes up. Yes? Guys, I need some feedback.
Yeah. Yes. Yeah. Sorry.
Yeah. Okay. So now adrenaline is going to continue, the heart rate is going to continue being raised because the adrenaline is still running. We've now gone in, we've assessed this lady, and we are going to administer some terbutaline. So terbutaline is a beta-2 stimulant. What effect is that supposed to have on the heart rate?
Increase it.
It's supposed to increase it. Okay. But with the improvement of the baby's condition, the adrenaline should start fading away, which means that the increase from the terbutaline is gonna be replaced by the drop from the adrenaline going away. It's basically gonna pretty much stay the same. So the baseline is not gonna go down, but it should not go up. Does that make sense?
Mm-hmm.
And it's only until when the terbutaline is wearing off, so about 2 hours later, that the baseline should settle down.
Okay.
So we're going to start off with a normal baseline. Adrenaline kicks in, so the baseline goes up. We've given terbutaline, and as the adrenaline is wearing off, the baseline is supposed to be coming down. So the terbutaline is going to stimulate the heart rate to potentially go up, and it will basically just stay the same until the terbutaline is wearing off. So what do you think would it mean if the baseline actually went up after I give terbutaline?
The baby is still stressed.
So it's either that the baby is still stressed, so the adrenaline has not gone away, or
Well, there's an infection as well.
Or there was no adrenaline to start with, and this was actually an infection. So the rise in baseline was not necessarily because of the adrenaline, it was actually because there was an infection going on, and you have just now made the baby more tachycardic rather than being better. Does that make sense?
Mm-hmm.
Yeah.
Now, a very important point, the other thing is that variability should not just go off. If the virility has gone off, that means the adrenaline is now working, the terbutaline is stimulating the baby to cause even more tachycardia, which is putting more overload, and that's basically causing brain vasoconstriction. Does that make sense? Hello?
Yes, yeah, it does make sense. Sorry, I'm just processing.
Okay. Okay. Now, many of you have talked, you know I love terbutaline, yes? Now, what's the side effect that you can get from terbutaline? Or what's the risk that you can potentially cause by terbutaline?
For the baby.
Baby or mum?
Tachycardia is the main.
Yeah.
So mum would become a bit tachycardic. You need to warn her that she is also going to potentially become a bit more shaky. You want to change? She may become a bit more shaky. So if she's an anxious woman, you need to warn her that this is going to make you feel a bit more shaky. Okay. Anything else? What are most people scared of? Why do they not give terbutaline before they do a cesarean section, for instance?
Oh, because of PPH.
Okay. So how many of you actually seen a PPH after terbutaline?
No.
I've never actually seen one, because I'd be happy to see somebody who has seen one.
I haven't.
I have never seen one. I actually give terbutaline frequently. If the head is deeply impacted, I need to get this baby's head out. Okay. Or if I'm doing a cesarean section for after a prolonged rupture of membranes. Okay. I frequently give terbutaline as I'm starting the section, and I've never had a PPH with that. It actually makes the delivery easier. So don't be scared of terbutaline. It does not, and you have much stronger uterine stimulants that can counteract any PPH that you may potentially even think of getting. Does that make sense?
Mm-hmm.
Yeah, definitely.
Okay. What about GTN? We said GTN, we give it for the same indications, or for fetal distress. We potentially can also give it if there's a deeply impacted head, a cesarean section, or as we're starting cesarean section. Okay. The intended benefit, we're going to see spacing out of the contractions. The reason I don't use GTN is because frequently the most common side effect is hypotension. And if I'm giving this for fetal distress, causing hypotension is not necessarily going to be helpful, because that's going to reduce the perfusion for this baby. So if I am starting with, okay, she's hyperstimulating, or I'm doing a category 1 cesarean section, I've just given her a spinal that's causing hypotension. I'm going to give her some GTN that's going to cause even more hypotension. What do you think is going to happen to the hypoxia? It's going to become much worse. Yeah? Does that make sense?
Yes.
Okay. So I'm mindful that we're overrunning a bit. So let's talk about antihypertensives. Number 1 line drug for antihypertension is labetalol. Is that correct? That is our first line medication according to NICE guidelines. Is that correct?
Yeah.
Okay. What is labetalol? Do we know?
Beta blocker.
No, it isn't.
Is it not?
No, it's not. It's not just a beta blocker. No.
Oh, it's not. And an alpha blocker.
And alpha blocker. Yes. So it is alpha and beta blocker. Labetalol literally blocks off the entire sympathetic system. Okay. The antihypertensive effect of labetalol is actually more from the alpha blockage rather than the beta blockage. Okay. Or as it both together, but it blocks both, and that's a very important thing. The reason being is that, okay, I'm giving this as an antihypertensive. This medication crosses to the baby. What do you think the picture is going to look like on the trace once you've given somebody labetalol? So let's describe a trace that has.
Will the baseline go down?
So why? Why would the baseline go down?
Because you just said, oh no, it will go up because you just said it. What did you say? It suppresses the sympathetic.
It blocks
or
the entire
parasympathetic?
sympathetic. It blocks the entire sympathetic system. So the baseline will go down
So
because.
So it'll go down.
It will go down, but why?
Because the sympathetic nervous system isn't working as well, so the parasympathetic pulls it down.
Yes. So the parasympathetic is going to pull it down. Correct. Okay. What about variability?
Well, I always used to tell everybody it reduced it, but now I don't know why.
Well, what is variability? So it will reduce it. That is correct. Why would it reduce it?
Oh yeah, because of the sympathetic.
Yes, because of the sympathetic. Variability is the interaction between sympathetic and parasympathetic. If you've taken away the sympathetic, your variability will be reduced. So yes. Okay. Accelerations. Would those still be there?
No,
Why not?
because of the sympathetic nervous system again.
But accelerations are not because of the sympathetic system, are they?
No,
They're because of the somatic nervous system.
nervous system, yeah.
So accelerations should still be there. If it's because of baby's movements. But shouldering on variable decelerations or the cord compression ones should not be there or would not be there because these are sympathetic. They're not somatic anymore. Yeah? Decelerations, would they be there?
Yeah.
So decelerations would be there because they are triggered by the parasympathetic. These are vagus nerve, yeah? Okay. Now, so you basically have described a trace that has a low baseline, reduced variability, still some accelerations when baby's moving, and there's still decelerations if we get cord compressions and if we are getting hypoxia or hypoxic events. Okay. Now, if this baby is getting more and more stressed, what normally happens is that the baby starts the process of redistribution. So the baby secretes adrenaline to try and cause what? Peripheral vasoconstriction. Can this baby do that?
No.
No, it can't. So this baby can't redistribute very well. Okay. Can this baby raise its baseline because of hypoxia?
Not as effectively, no.
No. Okay. If this baby is stressed and you figure out this baby is stressed, can you tocilize this lady with terbutaline? Terbutaline is a beta-2 stimulant, and you've given an alpha and beta blocker. Say that again.
You can, but
Ellie
it's effective.
It's not going to be as effective. Potentially. Sorry, say that again, Katrina.
Oh no, Ellie's just saying that. So Ellie's saying that on oral labetalol, we tocilize women regularly.
Well, use terbutaline.
With terbutaline.
Okay. Yeah, that's fine. Okay.
You've
I'm
been
gonna
kicked out the room, Ahmed.
But if you're
Yes,
on high
sorry.
sorry. It's been more just the effect is more than
You've been kicked out the room.
Sorry. One moment. I'll be.
beta blockers, the beta agonists tocilize the same. Where is it?
Not sure.
Perfect. I have an empty room.
I think it's left the building.
I left the building. Sorry, guys. Sorry, Ellie, I didn't hear what you were saying. So you were saying that somebody on oral labetalol.
Hmm? He's just saying he didn't hear what you said before.
What was the question?
I was asking about terbutaline with somebody who's on labetalol.
So it would be less effective.
So it would be less effective, potentially not effective at all.
Yeah, but but we use I mean, I've used terbutaline loads of times on women who are on like oral labetalol, who are hyperstimulated. But if you're using intravenous labetalol, my experience is that it doesn't really work.
So if you're using intravenous labetalol, you're on such a high dose that you're not going to work at all.
Exactly. Yeah, that's what I'm saying.
Oral labetalol is obviously variable.
Hmm.
So there are some that can respond, but it's not necessarily going to respond as well, and it's not going to be as long acting either. So it's not going to be as prolonged either. So be very mindful if you're giving terbutaline to somebody on labetalol, because it may not work.
Yeah.
Okay.
Okay. Ahmed,
yeah.
Sorry, can I just ask, with this terbutaline and not labetalol or not labetalol, how many doses would you give, and how far apart? Yeah.
So the dose for terbutaline is usually 250 micrograms. You can repeat it in 15 minutes. So once. So the maximum is 500 micrograms within 4 hours. That is not a trial. That's not. These are trials from asthmatic patients. These are not trials from pregnant women, but that's the safety profile that it has from asthma. So 500 micrograms within 4 hours. So you can potentially give 250 micrograms every 2 hours. Does that make sense?
Yeah, I've just seen it given a lot more, but you wouldn't recommend it?
No, I wouldn't. We're doing a virtual teaching session. It's a busy place, Kingston, you know? Sorry. So the whole point I was asking, so let me just ask I'm losing track of the teaching, sorry about that.
We were talking about the dose of terbutaline and how.
Yeah, so 250 micrograms every 2 hours, that's usually the maximum I would give. I wouldn't be giving more than that. I don't think it's licensed for more than that. Although I don't think you would get toxicity for more than probably 1 milligram within 4 hours. But we don't want to be anywhere near that level. So if you're giving it more frequently in higher doses, that is basically your own responsibility. We're using it outside the licensing. Does that make sense?
Yeah, thank you.
Now, as a precaution, before we move on from that, remember the original tocolytic that was always used in the past was something called Rytodrine. Rytodrine was a longer acting beta-2 stimulant that we used to use in tablet form for many weeks. And that used to have problems with cardiac patients, and that used to push them into heart failure. Terbutaline and salbutamol is shorter acting, still a beta-2 stimulant, but it's shorter acting. So if you're giving high doses of either or, so terbutaline or salbutamol, just be very mindful of what you're going to do to this baby's heart. Yeah?
Mm-hmm.
Cool. Now, going back to the picture effects. So the baby with hypoxia, the baby we started off with, or the baby before the hypoxia, start off with a low baseline. Variability is already reduced. We saw some decelerations. And then what? How do I figure out that this baby is well? Because this baby is not going to be raising its baseline that well. Okay, the baby is not going to be showing the deep, wide decelerations that we expect anymore, because these are triggered by the redistribution. And this baby is now just suddenly going to start showing that it's asleep. So variability is going to go off, and I'm going to think, well, maybe it's cycling. How do I figure out whether this baby is well, or is it just well and asleep, or is it just unwell now and it's lost variability because this baby is decompensating? Because in all situations, the baseline is going to stay the same.
Because you said it can still accelerate as well.
It can still accelerate. Can I use that to my advantage?
Yeah.
So if I stimulate the baby, the well baby is going to accelerate. If I stimulate the baby and it doesn't accelerate, then this baby can be unwell and is decompensating. Does that make sense?
Yeah.
Yeah.
Okay. So obviously I clearly love the beetle, yes? Okay, nifedipine. So nifedipine is, again, an antihypertensive and potentially a tocolytic. It's a calcium channel blocker. When I was training, one of the contraindications was to give nifedipine with magnesium sulfate because they're both anti-calcium. They both block the calcium from the channels. They can potentially cause profound hypotension. So be very cautious if you're giving nifedipine with magnesium sulfate. It has now become a relative contraindication rather than an absolute contraindication, but be just very, very cautious because they both work in the same way and they can have synergistic effects. The advantage of nifedipine, though, is that it does not affect the sympathetic parasympathetic system at all, which means that baby is going to be responding pretty much as it's supposed to respond. Does that make sense?
Mm-hmm.
Okay. So miscellaneous steroids. Do we know what effects the steroids has on baby? As in the betamethasone, the betamethasone that we administer.
So we give it for lung maturation.
Okay. Does it have any potential harmful effects? Why do we not repeat steroid dosages?
Can affect growth and things like that.
Yes, it can affect growth. Can it affect the baby's brain?
Yeah.
Yes. Okay. So one of the interesting things is that we don't give non-steroidals because it causes closure of the ductus arteriosus. Is that correct? We said that last time.
Mm-hmm.
Diclofenac causes closure of the ductus arteriosus. It can cause pulmonary hypertension. One of the interesting things is that steroids causes a more profound closure of the ductus arteriosus, actually cause more profound pulmonary hypertension. So when you're comparing the non-steroidals, they're always comparing it to the effect of betamethasone. Interesting. Okay. Obviously, the benefit of steroids is that it causes the lung maturation. So hopefully we can give it and deliver the baby soon after and the baby's happy. But even that effect goes away within a week. So timing of steroids is crucial. Yes? That's the whole point of the QUIP algorithm. Because not everybody needs steroids when we give it to them. And then they deliver 6 weeks later when they're 32, 34 weeks, and now we can't use it anymore. Yeah?
Mm-hmm.
What effect would it show on the trace after you had steroids? It makes the baby a bit more sleepy. There's less cycling.
Okay.
Yeah? Okay.